5, 4, 3, 2, 1.
Now, ma'am, we can start. We
Good
are live.
afternoon, everybody. Welcome to the series of PG Mentorship Program. Today we have the continuation of this program. Today we have two very eminent speakers with us, Dr. Sirisha Varala and Dr. Madhulika. And as you all know that this PG Mentorship Program is oriented towards the postgraduate learning. So the topics discussed here will be very much useful in the learning of the postgraduates and their bedside clinics and also in the examinations. Can I request Dr. Sirisha Varala to please take up and start her presentation?
Sure, ma'am. Thank you so much. So very good afternoon to one and all. Before I begin, I want to thank the organizing team and Sudharani ma'am and Nazia ma'am for this wonderful opportunity. So my topic here for today is bedside tests in dermatology and why they are important. So what is the relevance of learning these bedside tests? Now, first thing, even though we don't get a diagnostic confirmation, at least they aid in immediate corroboration of a suspected diagnosis, and they also assist in narrowing to a differential diagnosis. Definitely the results are rapid. Within minutes to hours, we can get the results, not days, as opposed to biopsies and cultures. Definitely cost effective because we require minimal equipment and reagents. And sometimes we can directly visualize the pathogens without waiting for the culture results. And what is most important is in resource poor settings, they have definitely an advantage. So first, let us begin with the basic staining, that is gram staining, which every postgraduate must know. So this is aimed at looking at the bacteria. In 1884, it was Hans Christian Gram who first described this technique. It helps in looking at the presence of bacteria and helps in guiding the empiric therapy, whether it is gram positive or gram negative organisms. So what are the steps involved here? So first we take the smear and heat fix it. So the specimen can be anything. It can be a pus or the base of an erosion or the blister fluid, and we can heat it to fix it. We apply the primary stain, which is crystal violet, and we wash it after 30 to 60 seconds. Now, after that, we apply grams iodine. This is because this acts as a mordant. It forms a complex with the crystal violet and helps in proper binding of that primary stain. Then we decolorize it with acetone. That will remove the stains from gram negative organisms. So the crystal violet is taken up only by gram positive organisms. Gram negative organisms are not going to take it up. Now we give a counter stain with carbol fusion, which will stain the gram negative organisms pink, and we look under the microscope. So blue or purple organisms are gram positive and pink colored organisms are gram negative. So what are the clinical scenarios where it is useful? So especially the common things we know, bullous and non-bullous impetigo, folliculitis, furuncles, we all commonly do. Now, the first picture here, if you see, this is an area where we are most of the times confused with herpes simplex. So we see group blisters, but most of the times it turns out to be just a bullous impetigo. So here in such cases, doing both a gram stain and a Zank smear will be useful in confirming the diagnosis. And of course, lesions like these folliculitis, just scrape the pus and do a gram stain. And what is interesting is botryomycosis, which is caused by Staphylococcus species. Here also we'll be able to, they form these black colonies or the grains, and take those grains, crush it under the cover slip, and then you can do a gram stain and identify the staph species. Now, what is most important is conditions like this, ecthyma gangrenosum, or meningococcal infections, where we need immediate therapy. Gram staining can be a useful adjuvant. So in cases like ecthyma gangrenosum, it is basically caused by Pseudomonas. So we need antibiotics targeting Pseudomonas. And in meningococcal infection, if you have lesions like these, like blisters or eroded lesions, you can always take, when there is active bacteremia, you will get a positive gram stain for meningococcus. So what do you usually see in gram stain? Either gram positive organisms or gram negative. So first you see whether they are pink colored or blue colored. Blue or purple colored are gram positive, pink are gram negative. Again, you see whether they are cocci or they are bacilli. Cocci are rounds and bacilli are rods. based on which we will decide the antibiotic therapy. And you can conditions like ecthyma gangrenosum, you can also do a touch smear. So here you take a biopsy and you are going to touch the underside of the biopsy onto the slide, and that touch smear you can go for a gram stain which will also show the bacilli. Now, another modification is acid fast stains, where we do it in case of mycobacterial infection. This is because the mycolic acid here is not going to take up the gram stain, so we need special staining. This is especially important in conditions like Hansen's and cutaneous TB. So how do we do it? We take the sample and we smear it on the center of the slide. Here we need thinner samples, smaller samples to prevent cell clumping. Dry the samples, air dry it completely, or you can also do heat fixation. Then you apply carbol function. So you can place an absorbent paper over the sample and saturate it with the stain to avoid overstaining. Then we heat the undersurface of the slide. It should not boil, just the steam should rise for about 5 minutes and rinse it off. You are going to add a decolorizing agent, which is 3% hydrochloric acid with alcohol for 2 to 5 minutes until the runoff is clear. Then you counter stain with methylene blue or malachite green and give the final rinse. And you examine under the microscope to identify the AFP. Now, slit skin smear procedure for detecting leprosy bacilli is something which every postgraduate must know, because they are going to ask you to do it in your practical examinations. So it's important that you know the technique properly. The site selection is important. Earlobes is a site which we commonly do, but prefer multiple sites. Clean the sites with alcohol. You are going to perform a linear incision and scrape the dermis sample up to 5 to 7 millimeters long. Then you take that and smear from periphery to the center. Then you're going to air dry and fix it with 10% formalin. Then you apply Ziehl-Neelsen staining as described earlier and examine under microscope. So what do we see? The AFB will appear like this. Pink color rods, and they can be individual bacilli or grouped like this. These are called as globi. So in cases like lepromatous leprosy and histoid Hansen's, the sensitivity is almost 100%. So slit skin smear allows us in estimating the bacterial index so that we know the patient's bacterial load, which helps in monitoring the disease progression and also tracking the response to treatment. So calculating BI index is something that we all must know. BI will calculate both the live and the dead bacilli in the skin, and they are scored on a logarithmic scale called the Rayleigh-Joplin scale from 0 to 6 plus. Whereas MI is only the viable solid staining bacilli. But MI is a rapid indicator of treatment efficacy. Within weeks, it drops. Now, cutaneous TB, the role is limited only in multibacillary TB, like in cases of scrophulodema, where you see evident pus coming out from underneath, or acute miliary cutaneous tuberculosis or tuberculosis cutis orificialis. You can always go for Ziehl-Neelsen's technique. Next, let us see the KOH mount, which is another common procedure we all perform in our OP procedure, OP days. So here, this is mainly focused at seeing the fungi. So what is the procedure? We take the sample, be it the scales from the tinea infections or the hair or the nail clippings, and we place it on a glass slide. We add 1 or 2 drops of 10 to 40% KOH solution, and we place the cover slip, and heating will only speed up the clearance, so it's optional. We allow for 5 to 15 minutes. It is greater in case of nail because it takes a longer time to dissolve, and we examine under the microscope. Now, here are some practical points which will help you. So first thing, identify the high yield sites. So if you are looking at the annular lesions of tinea, then it is from the edge of the lesion that you are going to scrape the lesion. So from the edge, from the active edge, the papule or a pustule or the scale is what you're going to take. Now, if it is onychomycosis, then if it is superficial onychomycosis, you scrape the upper layers and try to take the deeper layers. And if it is distal and lateral onychomycosis, always try to take the subungual debris. If you are aiming at candidal onychomycosis, then you will have to take the samples from the lateral and the proximal nail fold. Then, if you are suspecting tinea capitis, then dull lusterless hair is what you have to choose. Now, to enhance the visualization, now this is the condenser. The arrow is pointing towards the condenser of the microscope. If you want to see fungal elements, the condenser has to be down. You have to lower the condenser. So if the condenser is up, you have to lower the condenser, that is when you will be able to see the fungal elements in epithelial cells more clearly. So I don't know if you can appreciate, but this picture, the first picture is when the condenser is high. It'll not be visible. The second picture is when you lower the condenser, that is when you will be able to appreciate the fungal elements. Then again, always use a number 15 scalpel blade for the scales, and Wood's lamp is one adjunctive where you can use it to pick the sample, especially in cases like tinea capitis. So the fluorescing areas are where you have to pluck the hair from. So this is the classical presentation. Tinea capitis or corporis or even onychomycosis, we will see long branching refractile septate hyphae. So this is the classical description. In case of Malassezia pityriasis versicolor, we are going to see short hyphae as opposed to the long hyphae in tinea, and some spores as well, which is referred to as spaghetti and meatball appearance. In Candida, these are not real hyphae, these are called as pseudo hyphae. So basically we see these budding yeast cells. So from them they just grow longer and they appear like hyphae, which are called as pseudo hyphae. Now, not just superficial dermatophytosis, but even in subcutaneous mycosis and also in deeper mycosis, it is valuable. So what you're going to do, especially in chromoblastomycosis, suppose this is a plaque, you are going to select these black dots. This is where you have to take the sample from. So you smear it on the slide and add KOH. You will be able to see these copper-penny or medlar bodies. Similarly, lobomycosis, we don't have the cases, but if you suspect, you can always take a smear from the raw area and add some KOH. There you'll be able to see coupled or double sperules with a thin wall. And especially in mycetoma, you can have black grains, you can have yellow grains. So black grains are almost always fungus, yellow can be fungi, or it can be actinomycetes. So here you have to do a KOH. In KOH from the grains, you will be able to appreciate the hyphae, or you can also go for a gram staining where you will see that filamentous bacteria, which is actinomycetes. And here is a case of blastomycosis where you can see a white-based budding yeast cell, which is classical for blastomycosis. So do definitely try out in subcutaneous mycosis as well whenever you see a case. Now, next, coming to the mineral oil preparation. This is for diagnosing predominantly parasitic infections. So sample collection is usually from the skin scrapings from the affected areas. We all know the circle of Hebra, that is where you will have to focus on. With a sterile scalpel, you have to collect the specimen. Then you will apply 2 to 3 drops of mineral oil onto the slide, and you take the specimen in a petri dish first, apply oil onto the slide, and then transfer that scrape material into the oil coated slide. Cover it with a cover slip and gently press it to just create a uniform layer. And you have to examine under first low power magnification systematically, and then you can go for the high power 100x oil immersion. So we look for the characteristic findings, which is in scabies, we see the mites, we see the eggs, and we see the fecal pellets as well. Now the sensitivity is almost 60 to 80% for a single scraping. Multiple scrapings will increase the diagnostic yield. So clustered scabies and institutional outbreaks, it's a very good procedure. So this is how under oil immersion the scabies mite looks like. And these are the scibella, which is the pellets, fecal pellets. Not just scabies, in demodex as well, whenever you suspect deciduosis, you can also do a KOH preparation. So this is a KOH preparation. You see erythematous papule or a pustule, you can take the contents and just add a drop of KOH. You will be able to appreciate the demodex. Sometimes you can also try doing a zinc smear. This is a zinc, first picture is zinc smear. The smear will take up, but the demodex will not take up. It will be nicely seen as a refractile organism. So do try in cases of suspected demodex cases. Then next, coming to the zinc smear, which is used in viral and bullous disorders. So the procedure is you select a vesicle or intact vesicle or bulla, then open the roof carefully, scrape the blister floor. You're going to transfer the material to the slide, and here the stain used is either Giemsa or Tolidine blue, and then you're going to examine under the microscope. So basically it is useful for herpes infections, we all know. Now the highest sensitivity is on the early vesicles, preferably within the first 48 hours. So what are we looking at here? We are looking at multinucleate giant cells and ballooning. We are looking at nuclear molding and margination. Now, multinucleate giant cells, yeah, we all know these bigger things are all multinucleate giant cells. Now, also look that the chromatin is marginated at the periphery, which is called as the margination of the chromatin. Nuclear molding is where one nucleus presses into the other nucleus, causing an indentation, which is called as nuclear molding, which is very characteristic. And you'll also be able to see the ground glass appearance of these cells. So all these points towards herpes infections. Now, you'll not be able to differentiate whether it is HSV1, 2, or varicella zoster virus. We can only tell whether it is a herpes infection or not. It's also important in molluscum contagiosum. So how do you scrape? Now you have to scrape the central part of the lesion, not the entire lesion, from the umbilicated central part with a 15 number scalpel, and you spread out evenly, crush it with a cover slip, and you add Giemsa stain. So what you see as opposed to herpes here is uniformly stained cells, which are called as Henderson-Patterson bodies. You can also do a KOH. These are all the viral affected uniform cells, monomorphic cells, what we call it as. So these are the HB bodies, which are pathognomonic. And another important condition, autoimmune blistering disorders, pemphigus vulgaris. So we all know, we can see nice, beautiful acantholytic cells. Apart from acantholytic cells, an acantholytic cell is a huge keratinocyte where the nucleus is very big and pushing the cytoplasm to the periphery, forming a rim. And these acantholytic cells form clusters here and there, which is very classical of pemphigus. Not just this, we can also see streptocytes and Sertoli rosettes. Streptocytes are white blood leukocytes, which are arranged in chains. This is a Sertoli rosette. So this is a keratinocyte, which is surrounded by the leukocytes, like a ring, which is a Sertoli rosette. Now, bullous pemphigoid, what happens? You will not be able to appreciate acantholytic cells. Mostly you will be seeing these pink cells, which are eosinophilic cells. That way it helps in differentiating. Now in Haley also, you will be able to see the acantholytic cell. So here's a beautiful acantholytic cell. But then you don't see the grouping that is there in pemphigus vulgaris. These cells are scattered widely. That is the difference, and no streptocytes, no rosettes. And even in LD bodies, Leishmania Donovan bodies, if you come across the case, always do a Zank smear. You will be able to identify this nice Leishmania Donovan bodies. So this is a table which summarizes the same thing. Pemphigus vulgaris, you see acantholytic cells, streptocytes and rosettes. So hypertrophic nuclei and peripheral rim of basophilic cytoplasm. Bullous pemphigoid, just eosinophils. Haley, you will see just the acantholytic cells. Darius, you will be able to appreciate corons and grains, definitely, if you try. Then we know viral infections, multinucleation. SJSTN, it is also important. You can try where you will see necrotic basal keratinocytes with a lot of inflammatory cells. Now, how do you differentiate from staphylococcal scandid cells, scalded skin syndrome? Here you will be able to see some acantholytic cells, but here the inflammation is very minimal. So even here it is acantholysis which is happening, but then the inflammation is very minimal, and necrotic keratinocytes with a lot of inflammatory cells goes in favor of SJSTN. Then next, coming to the wet mount examination. Wet mount examination is done for vulvovaginal diseases. So you take the vaginal sample, the secretions, with a cotton tipped applicator, or either from the blade if you're using one for examination, or from the secretions which are pulled within the introitus. You touch this applicator onto a clean glass slide and form an even layer of the secretions. You add a drop of, we are adding saline, no KOH, nothing. For that is the wet mount preparation. You place a cover slip, then just make sure you remove all the air bubbles and examine under low power scanning first, and then high power for detailed observation. So what are we looking at? We are looking at the morphology of the epithelial cells. We are looking at the type of inflammatory cells and the organisms. Are they normal or are they infectious? So normally what we see is mature epithelial cells, which are large polygonal cells with abundant cytoplasm and small nuclei. We will also be able to see some parabasal cells, which are smaller cells, more in menopausal ladies. The lactobacilli are common, normal vaginal flora there, small rods of varying lengths. And we can see leukocytes in the ratio of 1:1 with epithelial cells, which is still normal. What are the abnormal findings? Increased leukocytes. That is specifically seen with trichomonas infections. So most of the times we will miss out seeing trichomonas because they're very fragile organisms. Once they are out in the environment, they die immediately. You'll have to see the slide quickly as soon as you take the specimen. And candidal infection, you'll be able to see pseudo-hyphae yeast forms and budding yeast cells, vaginosis, bacterial vaginosis, clue cells. So I'll show you a clue cell, how it looks like with a lack of lactobacilli. So the first one is a normal smear. So you will just be able to see the polygonal the vaginal epithelial cells. In vaginal candidiasis, so these are the budding yeast cells and these are the pseudo hyphae. This is a clue cell here in bacterial vaginosis. A clue cell is the one which is studded with that bacteria so that the periphery, the margins are lost. So they are very ill-defined as opposed to see this normal margin which is very well-defined. This is the normal vaginal cell. This is a clue cell. So here the margins are lost because of the bacterial invagination. Then vaginal trichomoniasis, you will be able to see trichomonas only if you see it immediately. Otherwise, you see a lot of inflammatory cells. So I'll show a video. So this is how trichomonas looks like if you look at immediately. Very motile organisms and very, very um, pathognomonic for trichomoniasis if you see organisms like this. Then let us go to the hair mount examination. So this is for detecting the structural hair abnormalities. You're going to pluck 10 or 15 hairs from the affected area. You're going to mount it on the glass slide. You can also add KOH for better visualization. And you're going to observe the hair shaft structure and morphology under microscope. So various genetic and structural hair disorders can be diagnosed with this. So, for example, see the first one, Griscelli syndrome. So, you see a child with silvery gray hair. So, just pluck few hairs and mount it under the microscope and see. You will be able to appreciate one of our patients. So, you will see irregular pigment clumping, which is very characteristic of Griscelli as opposed to Chediac Higashi. Here we see the giant melanin granules, but they're very evenly distributed, regularly placed clumps, what we call it as this is irregularly placed clumps, which is mostly diagnostic because not everybody can afford a genetic testing. Now, Netherton syndrome, if you're suspecting Netherton's, is a nice trichorexis invaginata or bamboo hair where the distal portion invaginates into the proximal portion, forming a ball and a socket appearance. Very classical of Netherton syndrome. Now, if you suspect somebody with loose anagen hair syndrome, the pluck test is also positive. You just try to pull it out; it comes off very easily. Mount those anagen hairs under the microscope and see what is this. This is classically described as floppy sock appearance. So the cuticle is ruffled, and you see like a loose sock-like appearance, which is very characteristic of loose anagen. Monolithics. Here you see a normal shaft and then a constricted bead, a normal shaft and a constricted bead. So that is the beaded appearance with constrictions classical of monolithics. Trichothiod dystrophy, you will not be able to see under the regular microscopy. You need a polarized light. So if that microscope has a polarized light as well, then under the polarized light, they will be very, as you keep moving the light, the hair will it gets refractile and we see alternating light and dark bands, which gives the appearance of a tiger hair. Then coming to another important sign, Nikolsky's sign, which is again commonly performed in pemphigus group of disorders. So here we are applying lateral pressure onto the skin over the tangential pressure with the finger. When do we call it as a positive result? So as shown in the picture here, it's just beside the lesion, tangentially you are applying pressure. And if you are able to peel the skin off, the superficial layers of the epidermis shear away from the basal layer, that is classical of pemphigus group of disorders. Now, there are various types of Nikolsky's. Direct Nikolsky is where you're doing at a normal skin at a site distant from the actual lesions. Marginal Nikolsky is where you're doing just beside the lesion. Microscopic Nikolsky is where you apply the shearing force, but you'll not be able to see with the naked eye. You have to do a histopathology, and that is when you will see the loss of adhesion. But it is more sensitive than direct Nikolsky. False Nikolsky, that is usually seen in subepidermal blistering disorders. Now here, there is no acantholysis here. You just, at the erosion, you try peeling off the skin, it goes to certain distance and stops there and it heals rapidly. That is false Nikolsky, where you see in bullous pemphigoid, cicatricial pemphigoid, etc. Pseudo Nikolsky is where you see in drug reactions like SJS, TEN. There it is a necrosis of the keratinocytes which is happening and not the acantholysis. So still you will be able to do a Nikolsky sign, but it is not the proper Nikolsky sign because of acantholysis. Bulla spread sign is where you have an intact bulla like this. You apply pressure directly on the top of the blister. First, you mark the blister You apply pressure and you see if the blister is extending any further beyond. So if it is extending, you see the margins. Angulated margins are described for pemphigus vulgaris. Rounded margins are described for bullous pemphigoid. So what is the clinical significance? That's a very important tool for vesiculobullous disorders. A positive sign points towards acantholytic disorders, and a false sign or a negative sign will be towards subepidermal blistering conditions. Also an important indicator to differentiate between autoimmune bullous disorders and drug reactions like TEN. So try doing in all the cases. Then pathology test. So pathology is another simple bedside investigation where you can do in conditions like Behçet's disease or neutrophilic dermatosis, basically pyoderma gangrenosum, Sweet syndrome, etc. is one of the minor criteria for diagnosing Behçet's disease. So where you are going to take a needle. Now here the three things that you'll have to be mindful about. The needle should not be sharp tipped. It has to be a blunt one, which will increase the rate of positivity at least 20 to 22 G needles. And you will have to apply or prick the needle at an angle of 30 to 40 degrees and go into the dermis to a depth of 1.5 to 2 mm with the bevel facing upwards. That is when you're going to get a highest positive rate. So you can just either prick the skin or you can also inject normal saline into the dermis. So what are the findings? We see exaggerated pustular or papillary reaction within the next 24 to 48 hours. So you see at 24 hours, you also see at 48 hours, and you see something like this here in the clinical picture. But simple erythema is not positive. You need to have a papule which is more than 2 mm or a pustule which is definitely a stronger reaction. So there has to be some indurated reaction here. And very classical of Behçet's disease, but can also be seen in pyoderma gangrenosum, Sweet syndrome, IBD, etc. Darier's sign. Now, when you see conditions like this, urticaria pigmentosa, mastocytosis, so where immediately we can definitely, to a certain extent, we can make conclusively diagnose of mastocytosis. Just stroke the lesion, rub the lesion with a blunt instrument. It can be a tongue depressor, just your fingernail, or the blunt edge of a pen. But make sure you don't cause any trauma. It has to be blunt enough. Apply firm, sustained pressure for at least 10 to 15 seconds. No, not that you just stroke it off and you just leave it there. No, it has to be firm, it has to be sustained at least for 10 to 15 seconds. And immediately you will observe an urticarial response, a wheel and flare reaction, which is very characteristic of cutaneous and systemic mastocytosis. So within the first 1 to 5 minutes, it has to appear. Now, it can also be positive in conditions like juvenile xanthogranuloma, leukemia cutis, histiocytosis, etc. But very, very classical of mast cell degradation, which is happening in case of mastocytosis, which is a simple bedside test requiring no equipment. Then coming to Wood's lamp examination. This is another non-invasive diagnostic tool which is used to detect fluorescence, basically. So what is it basically? It's a handheld device which emits UV light. How it works? It has a mercury arc bulb with a Wood's filter. So this filter will help in getting the fluorescence. Normally the normal skin will not fluoresce under this light. But if you have certain bacteria, fungi or some pigmentary changes, we get a distinct color. So the wavelength is in the range of 320 to 450 nanometers and the light appears violet. We use it basically to detect some specific fungal infections, certain bacterial infections, and in pigmentary skin disorders. This is how the lamp looks like. Certain things to follow before doing this. The examination room should be completely dark and devoid of any other fluorescent sources. The skin should be free of any application. So if you have any mineral oil applications or salicylic applications, they can fluoresce and give a false positive reaction. After turning on the lamp, you wait for at least a minute before beginning the examination. Hold the lamp at least 10 to 30 centimeters away from the skin and conduct the examination. So this is how we use it more commonly for vitiligo. So vitiligo patch gives a nice blue fluorescence, almost diagnostic for vitiligo, and very helpful to differentiate from conditions like versicolor, where it looks white but there is no fluorescence. So you can compare the versicolor picture here as opposed to vitiligo here. And in conditions like erythrasma, you will be able to appreciate a nice coral red fluorescence. And you'll also be able to see the malassezia spots fluorescence in acne cases, the malassezia folliculitis, and other porphyrias also. It's a very useful investigation. Then a dark ground microscopy is something that we don't do nowadays, but because we need a dark ground microscope for that, a dark ground condenser basically, that helps in looking at Treponema pallidum. We just not only look at the morphology, but we also look at the motility, how it moves, the motility of Treponema pallidum. So we cleanse the lesion, be it a primary chancre or the secondary syphilis lesions, condyloma lata lesions. Then you abrade the lesion with a dry gauze, scrape it off with a scalpel, and try to express clear serous fluid. That is what we want. We don't want the tissue. We want a clear serous fluid. Place it onto the slide. Add a drop of oil to the condenser. So where it will act as an interface between the slide and the dark field condenser, and you examine under 100x magnification. So the serous exudate is what is required for a successful examination, and avoid drawing blood because it interferes with the observation. So if you have a dark ground condenser in your microscope, then definitely this is something worth going for. So I will close with certain clinical case scenarios. This child is an infant who presented to us with erythroderma, almost redness scaling all over the body, and the child appeared Cushingers. So when we inquired, the mother said she has been applying mometasone cream on and off. So when they apply mometasone cream, it is getting better and there is recurrence. So we thought of ruling out tinea infections, and we did a scraping, and yes, we did find nice filamental hyphae, and we examined the mother also who had tinea infection. So a simple bedside investigation which can avoid extensive infantile erythroderma, we usually evaluate very extensively, but always try to rule out these simple things first. Now, this gentleman again, he got admitted with erythroderma and scaling and erythema all over the body for almost 1.5 months duration. He got admitted under medicine, and they called me for a referral to do a skin biopsy. I almost went ahead and I was planning for a biopsy. After I noticed this picture, so you can see the lesions in the web spaces, I became little suspicious. Now, there was absolutely no itching here because of the energy. So I did not suspect scabies in the first place. But then after looking at this picture, I did not do a biopsy. I just took some skin scrapings and examined under the microscope. And it was teeming with Sarcoptes scabiei. So lots of mites, lots of eggs. And there were so many other attendants in the room. I examined all of them. All the family members turned to be positive. He is having uncontrolled diabetes. That's why he landed up in Norwegian scabies. So always suspect when you have the classical sites affected. Itching might not be a complaint most of the times. Another child with silvery gray hair. So here, just simple thing. You take the hair samples and place it under the microscope, and you see irregular clumping of the pigment definitely points towards Griscelli syndrome. So to conclude, what is the importance of knowing this bedside test? They are rapid, immediate results at the point of care. They are cost effective, definitely crucial. They give crucial diagnostic information. So all the postgraduates, please take some time out to do in almost all the cases, because only when you know what is normal, you'll be able to appreciate what is abnormal. So thank you so much for the opportunity once again, and any questions are most welcome.
Thank you so much, Dr. Sirisha. It was a great presentation covering all the bedside investigations. And this is very important part of the postgraduate learning. And this particular topic is very much important in the Viva VOC examination. So I think they should take notes and they should learn this. Thank you so much for giving this elaborate lecture. It was much useful to us also. Now I request Dr. Madhulika Ji. Can you please give your presentation? She is speaking on dermoscopy, which is very important for all the postgraduates as well as the practitioners.
Hello.
Yeah, Madhulika.
Yeah, am I audible, ma'am?
Yeah, you're audible.
Just give me a second.
At the end of the session, we'll have a group photo. So then that time you can on
Sure,
all
sure.
camera. Yeah.
Okay, just a second. Okay, ma'am. So my slides are visible, right? Hello.
Yes, ma'am.
The slide is being shared. Is it visible?
Yes, ma'am. Yes, ma'am.
Achha, theek hai.
Just put it
Okay.
on presentation. Yes.
This is fine?
Yes, ma'am. Yes.
Okay. So, very good afternoon to everyone tuning in. Myself, Dr. Madhulika. Today, I wanted to just make my presentation a little more fun because usually these talks tend to get a lot of monotonous, and I wanted to make it fun for the PGs who are just getting into the subject now. So I wanted to introduce you to Dr. Confoundus. He's a dermatologist and he is frequently confounded by diseases that look the same to the naked eye, lesions that don't reveal a lot, patients who are unresponsive to treatments. He keeps punching biopsy holes into patients to figure things out, and his patients probably hate him for it. So let's introduce Dr. Confoundus to something very magical called as the dermoscopy. Okay, so here we will learn how to spot certain patterns and to solve the puzzle that is our dermatological diseases. So I want to state that I have no conflicts of interest and no financial disclosures. So he wants to know, Dr. Confoundus, whether dermoscopy is really worth the hassle. So to him, I say, dermoscopy is a non-invasive technique. It gives us in vivo magnification, which is 10 times to 200 times of the original image, and it helps us visualize surface and both surface and subsurface structures. It helps in recognizing disease-specific patterns, and it will also carry diagnostic as well as prognostic values. There are certain dermoscopic features which can be predictors of good treatment outcomes. So it helps us plan the treatment of a patient more accurately. So also there is objective assessment of therapeutic response. So you can tell whether a disease is responding to your treatment or not based on whether the improvement of certain dermoscopic features is there or not. So also this is evidence-driven clinical decision making. So you're not guessing anymore. It also mitigates the need for investigations like biopsies. And it is also reliable procedural guidance. Say you want to do a biopsy, you know which site to biopsy from, right? And if you want to do a laser hair reduction, you want to know what kind of hair you have. So you can use it n number of ways. You can get creative with it. So now Dr. Confound is saying, yes, so no more biopsies then. But no, are pathologists really going to be scared for their jobs now? So once a gold standard, biopsy is always a gold standard. Histopathology will always take the crown. But what does dermoscopy help in then? It mitigates the need for unnecessary biopsies. It helps us in selecting the proper biopsy site, and it improves our diagnostic yield overall. So variety is the name of the game. There are so many dermoscopes in the market and also several variations of the existing dermoscopes. So broadly, they're classified into handheld and video dermatoscopes. And in handheld dermoscopes, the most common one we use is DermLite. So DL3, DL4, DL5 are the ones that most commonly people are using, DL4, DL5 being the newest, right? And in DL5, you get the extra advantage of having UV light as well incorporated into it along with the polarized and non-polarized lights. So the video dermoscopes are from Derma India. We have Ultra Cam Triple Light Source. You have Photo Finder. You have Firefly, Dynolite. So these usually require an attachment to a computer. So lots of USB connecting and everything, but you can show the patient on a bigger screen. So that is an advantage, and they offer much more higher magnifications than your handheld dermoscope. So that's how they're better. So now Dr. Confoundus is again confused. He's spoiled for choices and he is worried he might choose the wrong option, and maybe so are you. So how do you choose a dermoscope? So first, it depends on what quality of imaging you are expecting. Okay, if you are going for journal publishing, okay, so you need better quality images, right? And if you're going for presentations, yes, you need better quality imaging. And your budget, that is most important, how heavy your pocket is, right? So usually handheld dermoscopes are a little less pricier, video dermoscopes are more pricier. And the utility ultimately. So if you're somebody who is going to be working only in the clinic and you want something portable you can carry from one room to another, one hospital to another, then a handheld dermoscopes makes sense, right? And if you are somebody who is going more on the research wise of it, you are in a teaching facility, then maybe a video dermoscope and you have a dedicated room for the dermoscope, is a video dermoscope would be the right option for you. So before you can use your weapon, you should always know what it is. So maybe I can explain the parts of a dermoscope. So this is a DermLite DL4, which is the most commonly used dermoscope so far, because not everybody has the DL5 as of yet. So here you can see the parts, right? This is a viewing lens. This is a magnetic ring which attaches onto this universal adapter.
Yeah,
this is,
you're
by
not
the
able
way,
to see the slides, doctor.
Not from the first one, or just it's, hello?
This one, this particular slide, what you're showing.
It's not at all visible. Now it is. Hello.
No.
Hello. It's not. This one is.
No, ma'am. No, ma'am. Actually,
It's-
your share slide presentation is stopped.
Just a
Please reshare your presentation.
Now,
Now?
yeah, now it's it. Yes, yes.
Okay. You didn't see anything from the first?
No, from first it was there till
Acha, it suddenly disconnected.
yeah,
is it?
after your
हाँ.
types of dermoscope it went off.
अच्छा, ठीक है. Okay. So yeah, which
Ma'am,
dermatoscope
please share the
which was, yeah.
presentation. The Zoom screen is visible.
Green one.
Your
Ma'am, I'm
screen
from
sharing. Yeah.
technical team. Just stop your
Sorry.
shares. Reshare,
Okay.
ma'am.
And reshare, is it?
Reshare.
You
Yes.
want me to share window or share screen?
Share screen.
Okay. Now?
Now select
Open
the
the PPT,
presentation.
ma'am.
Yes.
Yeah, okay.
Yes.
Make a full screen.
Full screen.
This is
Yeah,
fine?
perfect. Thank you, ma'am.
Yes, sure. Yeah. So we were talking about the parts of a dermoscope. So this is a Dermlight DL4, right? And this goes on to this universal adapter, which you can easily attach to your smartphone. So this is the viewing lens. This is the magnetic ring that attaches onto this universal adapter. This is the charge indicator. When your battery is charging, you will get to know lights will pop up here. This is the on and off button. There are two buttons on the side of the dermoscope. One is a pigment boost button and one is a mode switching button. Mode switching button will help you, toggle between non-polarized and polarized lights, right? And the pigment boost adds an extra layer of orange light to it to make the pigmentation more prominent. Okay. So, and this is the glass plate that goes in contact with the skin. If we want, we can remove it while doing polarized non-contact dermoscopy. This is a spacer disc. Okay. When you adjust and rotate this dial, you have to get it to a 0 to have proper view of the dermoscopic image that we're trying to see, the proper view of the lesion that we're trying to see. So, and this
Sorry
is the
to
charging
interrupt.
port.
The screen share, I think, is gone again.
I don't know why that keeps happening because I am sharing it.
Otherwise, Madhulika, you please share to technical team. They will
That
do
would
that.
be better.
Okay.
Yeah. How do I share it in the chat? Is that possible?
You have to send the presentation. I think you have to send the presentation to them.
Okay, then
Ma'am,
do
please
I...
mail to me.
हाँ.
I'm sharing my email ID.
अच्छा, please. I have sent it. Have you received it?
1 minute, ma'am. Check. No, ma'am.
I have sent it to Rohit.
Yes. Rohit.
Rohit.
Yes, 1 minute, ma'am. I'm checking, but I have not received it.
It shows a scent. Hello, have you received?
No, ma'am. No, ma'am. Can you share it
No.
on chat box? Technical team. Can we share the presentation in chat box? Yes, ma'am. Receive 1 minute. I'm sharing. Is my screen visible?
Okay, yes.
There is something, might be someone is on backside, just mute. Thank you.
So you'll change the slides for me?
Now, this is correct slide, ma'am?
Yes, yes.
Yes.
Okay, okay. So, this was recorded, right? The weapons, whatever the parts of the dermoscope and all. Do I need to again repeat the slide or just start from here? Go from here.
Start from this, ma'am. No issue.
अच्छा ठीक है so again I would like to reiterate the parts of a dermoscope. This is a Dermlite DL4. I think we missed out on seeing this image. So this is a magnetic ring which fixes onto the universal adapter. This is the viewing lens through which you'll be able to see your skin lesion, and then this is the charging light where it will, if it is fully charged, it will be 4 lights on. Then this is the charging port which is there, and then there are 2 buttons on the sides of the dermoscope. One is to switch between polarized and non-polarized light, and the pigment boost button adds an extra layer of orange light which will make the pigment more prominent. Okay, so other than that, there is the glass plate which goes in contact with the skin, which is usually with the non-polarized contact dermoscopy, and this is a removable plate. When you want to do a polarized non-contact dermoscope, you have to remove this face plate and then do it, and then put it back on when you want to do a contact dermoscopy. And this is the spacer disc. You want to rotate this focus dial and just get this to a 0 so that your focus is proper and you're seeing the best quality of image. Next slide. So principle of dermoscopy, we want to know how a dermoscope works. Normally, any light that is incident on the skin is going to be just reflected off the surface. So you're only able to see the top layer of the skin. So, but what happens, usually the refractive index of air and the skin is different. But when you put a glass plate on it, this refractive index is better matched. Okay, so your visibility of the deeper structures increases. So that's what happens when you put the glass plate of a dermoscope onto your skin lesion. So what happens is the light, instead of being reflected, it gets refracted, goes a little deeper and improves your visualization of a little more surface structures, but it doesn't go anywhere beyond a little superficial layers of your epidermis. So in non-polarized dermoscopy, you only see the superficial layers and you always need a contact medium, which is usually called a linkage fluid. It can be alcohol, it can be ultrasound gel, it can be just plain water or mineral oil. So it is dealer's choice ultimately, but usually depends on what site you're seeing. Say you're examining your nail plate, you want to use an ultrasound gel, you're using something like a very steady patch, maybe a mineral oil will look better. And if you're just seeing some infectious diseases, then probably using a 70% alcohol would be better, right? So these are the choices of the linkage fluids. Now, what happens in a polarized dermoscopy? How is it different from non-polarized? So normally this uses the principle of what is called as cross-polarization. Normally light is scattered in different directions, right? But when you place certain filters, cross-polarization, two filters which are perpendicular to each other. So when this multi-directional light passes through filter 1, it becomes unidirectional. Only the light that matches with the filter will go in and we get the polarized light. That polarized light penetrates deeper than your normal refracted light, and instead of just going in, it also changes its direction. So normally the superficial layers of the skin, there is only reflection, and the reflected, that's why the stratum corneum upper layer might not be visible in polarized light, but the light that has passed on hit other structures within the deeper layers, maybe the deeper epidermis and the dermis, so would go back scattered light from deeper layers would go up, pass through the second filter, and that is what improves the visualization of the deeper structure. So this is the principle of polarized dermoscopy. So there is also something called as wet dermoscopy and dry dermoscopy. Dry is without using a linkage fluid, wet is using a linkage fluid. So in non-polarized, always a wet dermoscopy, while in polarized, you can go dry or wet, and the non-polarized is always contact, polarized can be non-contact or contact. Okay, next slide. Next slide, please. Yeah, so there is also a new layer of what is called as dermoscopic examination of UV induced fluorescence. We already know about Woods lamp, and Sirisha madam has already talked about it. So the principle of the UV light, we are going to utilize this along with the polarized and non-polarized to give us a better idea of different diseases, especially not just infections, inflammations, carcinomas. There are newer findings that are coming to light as we use more and more UV induced fluorescence. There are, of what I know, DermLight DL5 is the one device which has UV induced fluorescence dermoscopy, and the other one is the triple light source of Derma India, which is a video dermatoscope that has been there since a long while, but incorporating it within a dermoscopy, handheld dermoscopy, is, I think, DL5 has a very good resolution. So how does UV dermoscopy work? So we already know UV light, and we usually use 365 nanometer. It's a lower wavelength, but it has higher energy and it has high refractive index. Okay, high refractive index, so the scattering is more. So when the UV light hits the skin, it excites certain chromophores in the skin, and when a chromophore is excited, it reaches a higher level, and when it jumps back down, it is going to release certain energy, which will be lower than the energy that initially excited it, but the wavelength will be higher. Okay, so this is what we call as the Stokes phenomena, right? And then because of this, the release of the lower energy but longer wavelength is usually in the visible spectrum, and you see it as a fluorescent light. So this light can be green, it can be coral red, it can be pink red, blue, white, dark, and that indicates different things when you look through your dermoscope. So just like with Woods lamp. Next slide, please. Yes, so this is an example of using the UV-induced fluorescent dermoscopy. The first one is erythrasma, where you can see the coral red fluorescence. This is because of the coproporphyrin released by the corynebacterium. The first image is before the treatment, and the second is after the treatment. So it's not just the diagnosis, whether the infection is completely cleared, you can distinguish based on the disappearance of the findings of the UV dermoscopy. The second image, where you see the pseudomonas Pseudomonas infection, you see the bright green fluorescence which happens because of pyoverdin released by Pseudomonas aeruginosa. The third one is in vitiligo. You see that the perifollicular pigmentation is more visible on UV light than even with polarized light. Okay, so you can there are n number of uses of using UV light within the dermoscopy context, and it is this area that's still being studied and new studies are being published. So I think that's something we should watch out for. Next slide, please. Next slide. Yeah. So dermoscopic features, when you look at a skin lesion through a dermoscope, there are certain things that are visible to us. They can be shapes like lines, dots, clots, globules, etc. And the color of these shapes, whether it is black, brown, gray, blue, yellow, orange, red, white, so many. And how these shapes, colored shapes are arranged within the context of a lesion, whether they're symmetric, asymmetric, whether irregular or regular, whether they are focal or diffusely arranged, or peripheral or central. So many different kinds of spatial arrangements. So this is the basis of all the features that you see on dermoscopy. Next slide. So let's get into the description of the morphology that is visible on putting a dermoscope. You can see lines which are like basically elongated structures, dots which are less than 0.1 mm and are round structures, globules which are more than 0.1 mm and they are also round structures. Clots are also a little bit of round structures that confluent solid structure without much of an internal pattern, basically like a blotch. And then structureless areas which lack any recognizable pattern. Circle where there is only accentuation of the border and nothing in the center. Pseudopods is like a extension, like a pseudopod like extension of the existing lesion. So these are the morphological features visible on dermoscopy. Next slide. So dermoscopic color chart is very important because that helps us decide pathology lots of times. So when we talk about melanin, based on the depth of the melanin, the presence of the melanin in which layer of the skin, you get the color. If it's in a very superficial layer, it is usually black. If it is in a little deeper epidermal layer, it is dark brown. If it is even lower, light brown, even like deeper into the dermis, it is gray, more deeper bluish or grayish blue. Okay, so these are like because of the placement of the melanin within the skin. And then if it is a keratin, you can see either yellow or orangish kind of structures. And then if it is white, again, keratin can be visible as white structures. And then even collagen or any fibrosis, sclerosis can also be visible as white. And if it is a vascular structure, red is usually for oxygenated blood, purple is usually for poorly oxygenated, deoxygenated blood. Next slide. So there are vascular and non-vascular features which become especially important in the context of papillosquamous disorders or certain carcinomas. So what kind of vessels do you see on dermoscopy? If you are taking a bird's eye view of the skin, and if the vessels are oriented perpendicular, you usually see them as dots or globules or glomerular-like vessels. But when you look at if they're parallel to the skin surface, you see them as more elongated kind of vessels. So basically dots, again, less than 0.1, globules are more than 0.1 in size, and glomerular-like vessels, which are almost like the glomerular apparatus of a kidney. It's like a tortuous dilated capillaries coiled together. And then comma-shaped vessels, again, it's in the name, hairpin, which is like a looped like an hairpin. And then crown vessels, arborizing, which are branching vessels, telangiectasia, which are vessels with same diameter throughout, corkscrew, and then linear vessels. So they are visible in different lesions, and a combination of features, not just the vascular, usually helps us make the diagnosis. Next slide. So next is non-vascular dermoscopic features, right? So non-vascular dermoscopic features, especially, when you are seeing like papillosquamous disorders, say you're looking at a lichen planus or a psoriasis, and you want to differentiate how. So not just the vessels, not just the pigment color, you also want to see what scales there are, whether what color they are, whether they are white, whether they are yellow, whether they are whitish yellow, whether how the scale is distributed in the lesion. Is it diffuse? Is it patchy? Is it central? Is it peripheral? And background color, this usually indicates what's going on in the lesion. Is it like more inflamed, less inflamed? Is it a regressing lesion? So based on that, whether it is light red, dull red, yellow, brown, black, gray, blue, violaceous. So that's how the background colors usually change. Next slide. Other than that, there are certain special non-vascular features, like you see in lichen planus becomes striae, which is indicative of histopathologically hypergranulosis. They come in several shapes also. They are white opaque structures that you can see. And then if there, because again in lichen planus or any other lichenoid disorder, there are gray blue dots, which is because of the pigment incontinence because of the basal cell degeneration. And then there are corn pearls. Okay, this is usually the follicular openings. They are filled with either keratin or some sort of flakes. So either komedo-like openings and corn pearls, usually seen in hypertrophic lichen planus. And milium-like cysts, like you see with seborrheic keratosis, which are more visible on non-polarized contact dermoscopy. And polarized, you might not visible, they may not be as much visible. So they resemble like milia, right? And then again, same the komedo-like openings, like I already said. Next slide. So again, the spatial arrangement, how these morphological features are arranged within the context of a lesion. Are they arranged peripherally around the lesion? Are they regularly distributed throughout the lesion? Is there branching like with vascularity? Are they irregularly, haphazardly arranged? Are they clustered arrangement? Is it patchy? Is it a string of pearls appearance? And is it a ring-shaped appearance? So based on how these morphological features are arranged within a lesion also gives us specific clues for diagnosis. Next slide. Yeah. So thinking about all these, so many features that you see on dermoscope, you look through a dermoscope, you see 15 different structures, and now you're questioning your life choices. Is there a method to this madness? Okay, next slide. Next slide. So yes, there is. So usually it is good that you follow an algorithm for dermoscopic evaluation. You initially start with dry non-polarized contact examination, then followed by dry polarized non-contact examination, then wet non-polarized contact examination. Then you again do wet polarized contact examination, and eventually in the last UV induced fluorescence examination. So that is the sequence of the events that's supposed to follow ideally. So what do you evaluate then? First, always look at normal to appreciate what is abnormal. So of the first feature, when you do a non-polarized, you might appreciate scales. Again, see the color, morphology, distribution, and then look at the background color as well. What is the lesion sitting on? What color is it? And then look at the pigment network. If it is a pigmented lesion, and is it something you should be paying attention to? How is the network? How are the pigmentary structures, etc.? Look at the margins of the lesion, well demarcated, poorly demarcated. That might give a clue. And then look at appendageal features. That is, look at the pilosebaceous units, how they are. Look at the eccrine openings. See what is visible, what is not visible, anything going in and around the appendages. And then look at the vascular features, their morphology, their arrangement, and any other specific signs, additional features that you need to know. So follow this algorithm so that you don't miss out on things. Next slide. So before you know what is abnormal, you need to understand how a normal skin, normal hair, and normal nail looks. So when you look at normal skin, if you're looking at the body skin, usually it is a true reticular pattern. Okay, in the reticular pattern, it's like a honeycomb, right? The holes, they correspond to the suprapapillary plates where the pigment is diluted, and the thick ring that is surrounding the hole is usually the retiridges with the concentration of the pigmented around the suprapapillary plate. So that is the usual, and they're not maximum you'll see is a little eccrine openings and all, but on the face you see what is called a pseudo-reticular pattern, that it is not a true network, but the pigment is distorted because of the openings of the pilosebaceous units, right? And then on the face, the pilosebaceous units are more prominent. So because of that, you get the pseudo-reticular pattern. Next, on the body, like I already said, it's a fine uniform reticular pigment network. And in the acral areas, usually because of the dermatophytes, it is interrupted. The normal pattern is interrupted. You see parallel furrow-like pattern. Next slide. So dermoscopy of normal hair and scalp as well. So normally when you look at a normal scalp and hair, Usually from one follicle, you get almost 1 to 4 terminal hairs per follicle. And most of the follicles are in that way. And these follicles are regularly arranged. Okay, there is no loss of follicles here. And the shaft diameter, if you could see, it's almost uniform. There will be very less terogen hairs compared to anagen hairs. And there will be usually no empty follicles. And the scalp itself, the intervening scalp, is usually light pink to skin colored. There is no inflammation, no vasculature much, and it presents very minimal vasculature. Next slide. And the normal nail, it is usually pale pink in color. It has a smooth, shiny surface, and the cuticle is transparent. And in the first and the second, the first 2 digits and maybe the third also, you can see a little bit of the nail matrix visible through the lunula. Okay, and the occasional longitudinal reading, which is considered physiological, so that is normal. Next slide. So dermoscopy, but there is so many different indications in which you can use a dermoscope. You can use it in inflammatory disorders, you'll call it inflammoscopy. You'll use it in hair disorders, you'll call it trichoscopy. Use it in nail disorders, call it onychoscopy. Use it in pigmentary disorders, call it pigmentroscopy. Use it in infectious diseases, call it entomodermoscopy. And then in skin cancers and miscellaneous other different kinds of skin. Every skin condition now can be examined by dermoscope and see specific patterns, most of them. So what use is of dermoscope? Like we already said, it helps in diagnosing the condition. It helps in predicting the prognosis as well. And it also helps us in deciding whether there are good predictors of treatment outcomes present, and therapeutic response monitoring. Am I audible? Sorry. Hello?
Yes, ma'am. Yes, ma'am.
Yeah. So therapeutic response monitoring, and then also guidance for doing procedures. Next slide. Next slide. Yeah, so the number one dermoscopic pearl that I can tell you is always, no, go back. Yeah, number one dermoscopic pearl that I can tell you is always correlate dermoscopic features with histopathogenesis for easy understanding. Otherwise, you're just looking at a string of features which doesn't make any sense, a string of signs that doesn't make any sense, right? So always understand, okay, this is a disease. This is why, this is what is happening. This is the cause. This is what happens on a histopathological level. And that is being reflected as what I see in my dermoscopic findings. Next slide. So let's just get into the common clinical problems that we usually encounter, and how to deal with it dermoscopically. So say you have a case of patchy alopecia, that is a patchy loss of hair. So you see one patch, but there are so many possibilities. Is it alopecia areata? Is it tinea capitis? Is it something else? So next slide. So when you look at a patchy loss of hair, what do you look at? I have given an algorithm so that you follow that so you don't miss findings. So first look at the openings of your hair follicles. First of all, are they present or not? That itself will help us in differentiating scarring and non-scarring alopecias. And if the follicular openings are indeed present, are they empty? Are they filled only with sebum and keratin, like in yellow dots? Are they filled with cadaverized hair, like with black dots? Is there plugging in it, like you see in DLE? Okay, so you have to look at the follicular openings closely. Then you look at the hair shaft proper. Now see if the hair shaft is normal. Are there enough number, like 1 to 4 terminal hairs coming from the opening? Are the hairs broken? Are they comma shaped, corkscrew, Morse code hair, tulip hairs, etc.? So any hair shaft abnormality should be noted. The diameter of hair also should be noted. So basically, the diversity in the hair shaft diameter might indicate a certain condition. Now, casts around hair, okay, which is seen, in certain conditions like pityriasis and alopecia. Then you also look at not just the follicular opening, but what is going on around the follicle. Is there scaling? Is there erythema? Which might indicate ongoing inflammation. So next slide. So usually non-scarring alopecias, we know alopecia areata, tinea capitis, trichotillomania, they're all very close differentials. So in the first image, you can see a lot of yellow dots. That normally in an alopecia areata, we know it's an autoimmune disorder. It's that our own body is attacking our hair and it's causing damage to the hair matrix and is causing it to cut off abruptly. Because of that, you see the black dots, right? And when this tries to grow out, again it will try to break. And because of the hair matrix damage, sometimes you see exclamation shaped hairs. And over the time, when this damage continues to keep happening, sometimes the hair follicle is completely shed out and you just see an empty follicle, so which are visible as yellow dots. But yellow dots is not only seen in alopecia areata, it's seen in other condition as well, but in alopecia areata it's more evenly distributed and more prominent. So these are the features. And sometimes when you have like a alopecia areata patch which has a good prognosis, you see hair that is already going back, short villous hair, also pigtail hair, circle hairs, which are like, they indicate that this alopecia areata will respond or is responding or will respond well to the treatment. So next is tinea capitis. This we know already, the infection, the fungus is invading the hair shaft. Either it is present on or inside the hair shaft. So when it invades the hair shaft, it is obviously going to cause a change in the direction of the hair. So basically it is causing the hair to bend. If it causes it to bend a little, it is called comma hair. If it causes it to bend completely because of complete invasion, it's a corkscrew hair. And again, in tinea capitis, you can see black dots as well, broken hair as well, and moss coarse head, because all this is because the fungus is invading the hair shaft. Next, we have the trichotillomania. Trichotillomania, where the patient is himself pulling out his own hair, right? So the hair is not like equally broken, it is broken at different and variant levels. You see some sort of a black powdery kind of this because of all the remnants of the broken hair that you see, right? And you can also see flame hairs, tulip hairs, V-sign hairs. Like basically the hair is splitting, and because of that you see all these features. Next slide. Now, when you talk about non-scarring alopecias, the common ones we know are lichen planopilaris, your DLE, and your frontal fibrosing alopecia. Now, we know in lichen planopilaris, for some reason, autoimmune inflammation is there against, and it's a severe inflammation. So, the entire dermoepidermal junction, there is interface dermatitis, and the basal cell is damaged. Eventually, there will be pigment incontinence, which will go into the dermis, engulfed by melanophages. Over the time, when this keeps happening again and again and again, eventually the follicle will start to fibrose. There will be scarring. When there is too much of inflammation, there's always scarring. So the follicle will fibrose and there is no more hair left. So we can, if you see in the first image, so here, this is the progressive site, okay? So you can still see the perifollicular scaling and erythema, but in the center where already the hair has been lost, you can see that there is almost a bluish gray pigmentation that is visible. And over the time, this is just going to become like a fibrotic area and there is going to be no hair coming out of it. So we know that we need to intervene. We know if the disease is active or inactive, and we look at these features. Next is you have discoid lupus erythematosus. So this has much more severe interface dermatitis than lichen planopilaris. So the features you see are also doubled up here, right? So you see telangiectasias because of the inflammation. You see blue-gray dots. You see brown pigmentation, loss of follicles, and follicular plugging as well, with follicles being filled with keratin and keratin material. So, this is like early stages, like in between stages of DLE. When it is a burnt out, all you can see probably is hypopigmentation and no hair follicles at all. And frontal fibrosing alopecia is almost similar to lichen planus, but it's limited to the frontal area, right? So here also you see perifollicular scale and erythema, blue-gray dots, loss of follicles, and white fibrotic areas. Next. So also the commonest thing we confuse is androgenetic alopecia versus telogen effluvium. So androgenic alopecia, you see, you have to note that there is hair shaft diameter variability. There's not all terminal hair. There are more villous hair also that are coming in. And you also see miniaturized hair. If you see the first image, the shaft diameter variability, you can visualize. It's not all the same diameter. And you can also see certain villous hair and miniaturized hair that are present. And because over the time they keep losing all the hair, you see more empty follicles. So that is yellow dots, and you can see a little perifollicular brownish pigmentation. Okay, these are all happen in little later stages of androgenetic alopecia. While in telogen effluvium, the number of hair coming from each follicle is reduced, but the diameter you don't see much of a change. Okay, so there can be empty follicles, but not as many as it is in an advanced androgenetic alopecia. Next slide. So if you see a scaly patch on scalp, now you're wondering, is it psoriasis? Yeah, is it sebopsoriasis? Is it seborrheic dermatitis? Is it tinea capitis? So these are all scalp scratching differentials. Next slide. So next slide, yeah. So how to differentiate between different scaly scalp patches? So first you look at what color the scale is. Is it silvery white? Is it yellow? If it's silvery white, more likely it's psoriasis. Yellow, more likely it's dandruff. Okay, in between could be seborrheisis. Scale arrangement, is it diffuse? The scaling is diffuse. Is it patchy? Is it only perifollicular? Is the scaling loose or is it adherent? Look at the follicle openings as well. Are they patent? Are they destroyed? Okay, so and any perifollicular changes you want to note, you can. So vascular changes, are there dots? Are there globules like you see in psoriasis? Are there linear vessels like you see in seborrheic dermatitis? Are there telangiectasias like you see in DLE? Are there any hair shaft changes like you see in tinea capitis, broken, black dot, comma hairs, etc.? And what is the color of the background? Is it pink and red like it is in psoriasis? Is it like, yellowish because there's not much inflammation, or mild yellowish to red as in seborrheic dermatitis? Next slide. So in the next, this image, you can see the scalp psoriasis. You see diffuse silvery white scales. You see the red dots, globules, and red background. The second is pityriasis capitis. You see the flaking is not as much as in psoriasis because the inflammation is not as much as it is in this thing. And because of the fungus, there's just mild inflammation which causes the scales to form like this. So here, more whitish yellow flakes and the linear vessels, very few dotted vessels, and more of a yellowish background. And in pityriasis amentation, which is like for because of different causes, you had like extreme compact orthohyperkeratosis, you see them as thick white adherent scale which almost form like sheets over the hair. Next slide. So if you see a scaly skin patch, at first glance, it might look eczema, second says psoriasis, and your brain says, help, I need help because I cannot differentiate. So that's where dermoscopy comes in. Next slide. So again, the same thing as you wanted to do in this scaly scalp patch, right? You look at the scale color, morphology, distribution, and then you look at the background color, you look at the vascular morphology and the distribution of these vessels in the lesion, and if any non-vascular features like you do with lichen planus. Next slide. So most of the papillosquamous skin disorders are what present as scaly skin patches, right? So this first example is of psoriasis, where you can see the white, silvery white diffuse scaling. The scaling is also, diffuse, and it is arranged throughout the lesion rather than patchy, right? And then you can see the regularly distributed dots, globules, and even in the image 4, you can see the glomerular kind of vessel. Sometimes it also depends on the magnification. The more magnification you look at, the vessels will look more coiled. So you look at it with the 10x magnification, it will look like a dot or a globule, okay, that thing. So now, based on the kind of, vessels you see, you can also tell about the prognosis of psoriasis. So say, you see more glomerular-like vessels. They say it's usually doesn't indicate a good response to treatment. Dots and globules have a better response to treatment, okay? So, and you can also monitor whether this vasculature is going down on starting the treatment. Are the scales reducing? So it is also an therapeutic response monitoring that you can do. You can also see a micro-auspit sign that you lift the scale, you rub it, and then you see a little bit of the dots. So we already know why you're seeing the scaling. It is because of the hyperkeratosis and parakeratosis. Why you're seeing the vessels? Because dilated blood vessels within the dermis, and we are seeing it as dots and globules because we are seeing it from above, and these are oriented perpendicular to the direction of the skin, okay? So and the background is definitely light red to dull red because there is ongoing severe inflammation that causes it to look that color. Next. So this is lichen planus. Now you can see in the first images different kinds of Wickham striae. Not just identifying Wickham striae, you should know what kinds of Wickham striae are there. Sometimes it is reticular pattern, like in the first. Second, branched Wickham striae. First one is radial streaming Wickham striae. Image 2 is branching, and the third ones are reticular pattern of Wickham striae. Wickham striae is what? It indicates that there is hypergranulosis in the skin that is being visible as the Wickham's. So, and also you see the background is more like purplish red kind for some, and then a little violaceous for some. Why? Because again, because of the ongoing inflammation, the dullish, dead red purple that you see, and because of the pigment incontinence and the dermal melanophages, you see the violaceous color. Also, like I said, comedo-like openings, and then corn pearls in hypertrophic lichen planus, where the keratin gets trapped within the follicles, you see that. And when it is a regressing stage, most of the time you just see pigment pigmentation rather than any violaceous features. So in pityriasis rosea, we again another inflammatory condition, but it's not too inflammatory, and it's like a lesion that spreads from center to periphery. So only it is active, it's inactive in the center, active in the periphery. So you see only a collarate scale. Next slide. So then pityriasis lichenoides chronica, which is a lymphoproliferative disorder where you almost presents like a scaly white hypopigmented patches, right? So what you see in this, you see fine white scales, you see sparse dotted vessels, a hypopigmented background, and a little orangish structureless this thing in your dermoscopy. Then you have eczema, which is again an inflammatory disorder, but the inflammation is not as much as in psoriasis. So here you see patchy yellow white scales, and then you see yellow clots, which are like the serous discharge that comes from this, and it crusts and it forms a clot. And then the patchy vessels, which is you don't see a uniform distribution of vasculature here. Next, porokeratosis is another disorder of hyperkeratinization. You see the coronoid lamella of porokeratosis being represented like a white track around the actual lesion, and in central you can see a little bit of atrophy and structureless areas. Okay, next slide. So next, coming to the onychoscopy, nail, right? Normally, when you look at nails, maybe is it fungus, is it psoriasis, is it trauma? The nail isn't talking and you want to know more. Okay, next slide. So when you can see discolored nails and dystrophied nails in your common clinical practice, right? So whenever a nail comes, anything with a nail problem, so you first look at the nail plate, you look then at the nail bed visible through the nail plate, you look at the nail matrix, the visible portion of it, and you look at the hyponychium, okay, and you look at the nail folds, and you look at the free edge, right? So first you look at the color, okay, is the nail brown, black, yellow, green, red? What is it? What color is it? What are the patterns within the nail plate? Are there any, if the nail is discolored, what is the pattern of the discoloration? Is it longitudinal? Is it in bands? Is it generalized? Is it in globules? You have to see that. And then you look at the edges of this discoloration. Is it regular? Is it irregular? It might indicate a carcinoma. So also look at where it is originating from. Is it from the matrix? Is it from the nail bed? And what are the associated signs? Subungual hyperkeratosis. Are there any splinter hemorrhages? Is there a periungual pigmentation like Hutchinson's sign? So usually discolored nail, where all conditions you find it in infections like onychomycosis, pseudomonas, and then also some traumatic nail injuries, and then in melanoichia, different causes of melanoichia, erythronoichia, and leukonychia. Next. So if it is a dystrophied nail, again, it could be infections, inflammations, tumors, etc. Again, you look at the nail plate surface, you see if there is any pitting, ridging, crumbling, fissuring. And you look at if there is any onycholysis, and if at all there is an onycholytic border. Is it clean? Does it have erythema surrounding it? And look at the subungual hyperkeratosis. Is the hyperkeratosis friable? Is it compact? Is it present? Is it not present? Splinter hemorrhages. So are they present or not present? Oil drop sign, pterygium, these are certain specific signs, like with psoriasis or with lichen planus, you see them. Next. So discolored or dystrophied nail. So let's start with onychomycosis, which is the commonest condition we encounter. Okay. So usually this has a discoloration, jagged edges, which have jagged edges with spikes. The ruin pattern is the subungual hyperkeratosis. Okay, you see a friable hyperkeratotic material under the skin. So basically what is happening is the fungus is going under the nail and starting to infect the nail plate, nail bed, everything, and eventually the entire nail unit is affected, right? So when it is affecting the nail bed, so there's more hyperkeratosis being generated, and that is more friable compared to psoriasis, where it's more compact. So also you see different colorations within the same nail. You can see this is called as aurora borealis, and then you have melanonychia, which is like entire the nail has become completely black, right? And pseudomonas nail, it is irregular greenish brown discoloration that you see. So you can differentiate between normal pseudomonas infection and a fungal infection. Next. So next you have the traumatic onycholysis, where you see a clean transverse onycholytic border and you see certain subungual hemorrhages. Then you have melanonychia. Usually when you see a discolored nail and there's a melanonychia, either it is due to melanocyte activation or melanocyte proliferation. Activation means the amount of melanin being produced is increased, while in proliferation, it is like number of melanocytes are increasing. Where are number of melanocytes increasing? In a nevus or a lentigo, right? But they're still benign. And then where is it activating? It can be because of drugs, because of continuous trauma. It can be physiological. It can be changes in hormones. So there are many things that result in a melanocyte activation also. So how to differentiate between a melanoma and a benign melanonychia? So usually in a benign melanonychia, there is a single color which is homogeneous. The band is regular. There's no irregularity to it, and there is no Hutchinson sign. Sometimes there is a pseudo Hutchinson sign, but it is not a true one where it is the actual cuticle the pigment is extending to. In a melanoma, you see color variation, right? The band is irregular, and you see the microscopic Hutchinson sign. So that is the differentiating factor. Next slide. So this is a psoriatic nail from what you can tell. So the first image, you can see the oil drop sign. Why that is? Because in the nail bed, there's a lot of hyper and parakeratosis. And because of that, and also the neutrophils and everything that's accumulating, it looks like an oil has been placed under the nail plate. So that's an oil drop sign or a salmon patch. And you see in the second image, the onycholatic border has a little bit of erythema surrounding it. Okay. And then you have the third image, you can look at, it is a subungual hyperkeratosis. It's very compact. Okay. Unlike the fungal, if you remember. And you also see the coarse pitting that you see, which is again because nail matrix mein there is parakeratosis, and this is causing the nail plate to shed off, okay, in those pit areas. Next slide, please. Sorry, no. Okay, this will do. So this is next is sometimes nail lichen planus, right? So and also certain eczemas. You see tracheonychia, okay, the 20 nail dystrophy. Sometimes it's also only few nails that are involved. So in lichen planus, we already know in the nail matrix there is severe inflammation ongoing, lichenoid infiltrate, which causes severe damage to the nail matrix. That's why you see nail bed different colors in the nail bed, which is called nail bed dyschromia. You see longitudinal streaks. You see crumbling of the nail plate, longitudinal ridging, splitting, everything. And pterygium, eventually this keeps happening again and again, and eventually the nail matrix is destroyed and almost a scar-like band tissue is formed, which we call it as a pterygium, right? And also the last one image is like lichen striatus, which is again the crumbling of nail bed in that one area along the direction of the skin lesion, like it happens. It's also again a lichenoid infiltration. Next. So there is also one important thing, that is nail capillaroscopy, okay, which is especially important when you are evaluating connective tissue disorders like scleroderma. So normally the capillaries, as you can see in image 1, are homogeneous hairpin-like loops which are regularly arranged. Sometimes these capillaries will increase in their width and they look dilated. Sometimes they are tortuous, not just the hairpin shape, they are usually like thrown into folds, but they are not crossing over each other. In meandering, they are looped as well as crossing over each other. In bushy capillaries, multiple buds are originating from the distal loop, and sometimes microhemorrhages can be noted. So these are all qualitative findings to note on nail fold capillaroscopy. Next. So quantitative capillaroscopy, usually all of these are not easy to do, but mean capillary density can be. So you see per mm of length, how many number of capillaries are present in the proximal nail fold. Next. So in a normal nail fold capillaroscopy, as you can see in the image, you see almost 2 to 5 U-shaped, hairpin shaped capillary loops that are present per mm. Okay. Sometimes there can be less, but that is unusual. So these are all regularly distributed. They are of almost even width and they're evenly distributed. Next. So what is abnormal then? In scleroderma, you know, the vessels are fibrosing. So the blood supply is disrupted. So in early stages, you see that there are a few dilated and giant capillaries. As the disease gets more active, there are more giant capillaries and more hemorrhage happening. And in the late stage, there will be loss of actual capillaries with certain dropouts that you notice. So almost it might become eventually avascular when there is no supply to the digits. Next. So the other common thing we have is every hyper and hypopigmented patch has a story to tell, and it is a long differential list for each. Next. So whenever you see a hyperpigmented black patch, basically look at what is the color and what is the depth of the pigment. Is it epidermal, is it dermal, or it is mixed? So if it is epidermal, it is black. If it is dermal, it is blue-gray. If it is mixed, it is brownish to blue-gray, depending on the depth of the pigment, right? What is the pattern? Is it reticular, homogeneous? Okay. What is the morphology of this pigment? Are there any dots, any globules present? How is the patch? Well-defined, ill-defined? And then is there any scaling on the surface? is there follicular involvement, or if there is follicular sparing, or if there is follicular plugging. Note that. See if there is any vascularity to it. Like say you're seeing a melasma, you know there are telangiectasias, so you know the vascularity is very active in that melasma patch, and any other specific signs according to the disease. Next. So when you see the first 4 images, they are of different depths of melasma, right? So you usually see exaggerated pigment network. On the face, you see pseudoreticular network. This pigmentary network is exaggerated in melasma because of the activity of the melanocytes, right? And based on the depth, you see the color, whether it is very dark or it is a little, completely purely dermal melasma is rarely visible. Most of them are either mixed or epidermal. If it is very dark, it is epidermal. If it is like a little less, it is mostly mixed kind of a melasma. The next is lichen planus pigmentosus. Again, one common skin condition whose incidence keeps increasing because people keep using different sorts of medications, hair dyes, etc. And nowadays, I keep noticing that there are more people landing up with lichen planus pigmentosa. And the commonest differential is ashy dermatosis. How do you differentiate from it? Okay, from pigmented cosmetic dermatitis, how to differentiate? Dermoscopy helps a lot. Okay, so when you see on the body, you see a hem-like pattern of the pigment clusters. On the face, when you see, usually there's no hem-like distribution, but there is blue-gray pigments. We already know in lichen, any kind of lichenoid disorder, basal cell damage, pigment incontinence, melanophages. Okay, so that is what is representative of these dermoscopic features. Next. So again, in EDP, you don't see much of a accentuation of a pigment network as such. You just see certain blue-gray dots, globules, and granules that you see. And in pigmented cosmetic dermatitis, sometimes you see gray blue dots and granules, but the pseudoreticular pattern of the face is highly exaggerated, okay, with almost a granular pigmentation surrounding this. And in exogenous ochronosis, and those who like misused hydroquinone, etc., you see the dark brown globules, elongated and curvilinear worm-like structures, which represent the deposition of the ochron, and then conjoined together in a reticular pattern. Next slide. So hypopigmented patch, again, look at the pigment network, whether it is present or completely absent, or it is faint, but it is still present. Degree of pigment loss, complete, reduced, or uneven loss. Borders of the patch, well-defined, ill-defined, serrated. Scaling, whether present or it's not present. Follicular features, if leukotrichia, perifollicular white halo, or there are no reduced follicles like you see in a leprosy patch. So like that, all follicular features you note. Vascular features, if anything, erythema telangiectasias, note them. And any appendageal loss like eccrine and hairs are not there in that area might indicate something very severe like a leprosy. Next. So when you see the image 1, you see vitiligo, right? You see this diffuse light glow, which is like in contrast from the normal skin. And sometimes you see the trichome pattern where 3 different colors are present, which is like a gradual progression of the vitiligo patch. Sometimes you see perifollicular hyperpigmentation. Previously, we used to think, okay, follicle around there is pigmentation, it's a good sign. But that is it after treatment, or is the patch progressing and from the follicles also, they'll eventually start losing color? So that needs to be seen. And is there any leukotrichia? We already know in vitiligo that the prognostic in dermoscopy has prognostic indicators and treatment response predictors, right? So you see if there is leukotrichia. If it is, then maybe the patch will not respond as well to treatments, right? And if there is perifollicular hyperpigmentation, that's a bad sign, okay? And if you see that the border is not well defined, that might again be a bad sign, okay? So these are some of the prognostic indicators. In IGH, it is also a diffuse white glow, but it is a well demarcated margin, and it has specific patterns like amoeboid or the petaloid, nebuloid, feathery, depending on the shape of it. So nevus depigmentosus is, again, it is usually a birthmark, but here the pigment is not completely lost. There's a faint pigment network that is present, and the borders are usually serrated. Next slide. And again, lichen sclerosis at atrophicus, right? Here you see because of the inflammation, you see that there is atrophy and sclerosis that you note, right? So because of this, you see the erythema, the vessels, the blue-gray dots, structureless white areas. So, but it is differentiable, okay? It is differentiable from vitiligo. Versicolor, you see a little bit of scaling, and the pigmentary network, even though it's diluted, it is actually present, and the scales are within the skin line markings. Pityriasis alba, again, a diluted pigment network, and you see a little bit of flakiness to it, but it is not not vitiligo, that you can clearly tell these things apart, because most of the time hypopigment patches are more about, there's a stigma attached to it. So you want to make sure that your patient knows that this is not vitiligo and they don't need to be worried about it. Next. So there are lots of times the commonest thing we encounter are itchy papular rashes in our clinical practice. So when the rash is itchy, but the diagnosis is scratchy, that's when dermoscope helps. Okay, next slide. So whenever you see pruritic papules, see what are the central structures. Is there a burrow? Is there a punctum? Is there a crusting? Vessels, are they dotted, linear, crown vessels? Is there follicular involvement? And then what is the color of the background? Is it red? Is it yellow, brown? What is the arrangement, okay, of the vasculature? And then how the general lesions, the papules are arranged within the context of your skin, and specific signs also, like jet with contrail, starburst, Wickham striae. These all you can look at. Next slide. So few examples, scabies, you see the jet with contrail appearance where you see the mite at the end of the burrow, right? And then you see the eggs and the sibala, and then a little bit of flakiness, scaling, and erythema also you might see in scabies. Lichen nitidus, because of the pathological, what you see, the infiltrate that is like a claw clutching a ball. So you see demarcated starburst-like hypopigmented white globules with central depression or umbilication, and a little bit of microcobners, that is active Kobner's phenomena appreciated through your dermoscope. So that is what you see on lichen nitidus. In prurigo nodularis, you also again see starburst. Starburst is mostly because your continuously friction is there, or some kind of a hyperkeratosis is there. Because of that, the starburst pattern comes. So central starburst, crust erosions, brown halo, and peripheral vessels are seen in prurigo nodularis. In lichen amyloidosis, what is happening? Amyloid, because the keratin is getting damaged due to friction, you start the amyloid deposition starts around the damaged fragments of the keratin, right? So here you see usually hub and spoke pattern, which is seen in lichen amyloidosis, with central white hub and peripheral spoke pattern, and a little bit of patchy vasculature you can see. Next slide. So again, moles are very common, and you always wanted, the dermoscopy arose from the need to differentiate a mole from a melanoma, normal mole from a melanoma. So is it a mole or is it a plot twist? So next. So moles, usually when you look at, see first if the lesion is melanocytic or not. How is the pigment network? Is it reticular? Is it globular pattern? Are there pseudopods? Is it a homogeneous pigmentation? Check for symmetry, okay, whether the lesion is symmetrical or not. And the patterns, like I said, reticular, globular, homogeneous, starburst, parallel pattern, what is it, you note. Then assess the uniformity of the color. Usually most of the moles have one or two colors, nothing more than that. And specific features, okay. And then the ABCD rule, okay. So the same thing, asymmetry, background, diameter, and all you need to note. So next slide. So moles in a melanocytic nevi, you know, either it is junctional at the dermoepidermal junction, or it is dermal, okay, or it is compound, which is both, okay. So in a normal melanocytic nevi, there is reticular. This is the first one, is a reticular regular pigment pattern. Next is a spitz nevus, which is almost like a junctional. So here you see a deeper, more stronger pigment in a starburst pattern, but it is symmetrical, okay. So and there is just one color and no variation in color, and the borders are well defined and not ill defined. Compound moles, you here again, the compound mole, the depth of presence of the nevus cells is different. So you see a little more diluted kind of multiple round globules without too much color, and mixed patterns are noticed in compound moles. Next slide. So whenever there is a suspicious lesion, okay, the commonest ones that we encounter are melanoma, squamous cell carcinoma, and basal cell carcinoma. So is the lesion melanocytic? You want to look and see for the ABCD rule. Again, like this, like I told, symmetry, borders, uniformity of color, the vascular features, and all you check, and check for any specific signs. Next slide. So in BCC, usually there are bacilloid cells which are mutated and which are proliferating, okay? And they are typically in a spoke wheel pattern, and peripherally they might be more exaggerated in cell and surround that is supporting this tumor. So you see arborizing vessels within it, and then because these are like heavily pigmented cells which can shift down, you see usually in a pigmented BCC, you see a blue-gray ovoidness that are visible. Sometimes erosions, ulcerations, etc. also are visible. In squamous cell carcinoma, again, the keratinocytes are mutated, are malformed. So because of that, you see the white structureless areas, the scales, and different sites of vasculature that's trying to support this tumor. And in melanoma, like I said, asymmetry, more than 3 colors, presence of an atypical pigment network, irregular dots and globules, pseudopods, extensions from the lesion, and then structureless areas, a blue-white veil when it is a deeper, it is spreading to the deeper areas, and then sometimes regression also. Next slide. So 50 shades of red, dermatology edition. So vascular lesions, one last thing I want to say. So is it a hemangioma? Is it a pyogenic granuloma? What is it a cherry angioma? Is it an angiokeratoma? How to make out? Next slide. Next slide. So whenever you see vascular, see if they are present in dots. Are there lacunae present? Are the lacunae empty or filled with blood? And if there is vasculature, see if they are linear, serpentine, anything. And then color, what color is it? Okay, is it oxygenated blood that is red? Is it like deoxygenated blood blue, or a mix which is purple? Are there any structureless areas, and are there any specific signs? Next slide. So the first one is hemangioma, where you can see reddish purplish globules and certain lacunae which are filled with blood. In angiokeratomas, again, these are superficial dilated vessels which they look like lacunae, which might be empty, or they have a hypopyon look filled with blood, and they have a frog spawn appearance, right? And you have pyogenic granuloma, which is again lobulated capillaries that are proliferating. So you see a reddish white homogeneous area with right railroad track appearance which are traversing through the lesion, and sometimes even there is a white collarate around this pyogenic granuloma which is demarcating it from the normal skin. Next slide. So in conclusion, at the end of this presentation, I hope all doctor confunduses are doctor confident. So the importance of dermoscopy is that you can see the details, you can detect early, you can diagnose better, you can treat better. And I hope you can't imagine dermatology without it going forward. Next slide. So hope you too master the art of how not to look clueless in front of the patient, because lots of times they come in and we don't know what is going on. So, but once you put dermoscope on it without doing a biopsy, you have certain clues to your aid that can make you look more confident in your diagnosis. So thank you and bearing up with me for this long presentation. Hello.
Hello, Dr. Madhulika. Hello.
Hi.
It was elaborate and a very wonderful presentation. Actually, it was very big presentation, so I was not able to concentrate the whole presentation. But I am very happy that the postgraduates have must definitely benefited a lot, and especially the difference how you showed in the trichoscopy, that is very much needed for all the dermatologists to differentiate between causes of hair fall and all. That was very much useful, I could see. And also the pigmentation, all the you have covered a very, I think you have covered the whole textbook of dermoscopy today.
I tried, ma'am, without trying to sound too boring. I tried.
Yeah, the whole textbook. I think when we discuss dermoscopy, we concentrate on each part, at least one day, one trichoscopy and one pigmentation, one scaling. But I think you have covered almost the whole dermoscopy today. So it will be definitely easy for the postgraduates who are preparing for the exams to go through the whole book easily. So I thank both the speakers, Dr. Sirisha Varala and Dr. Madhulika, for this wonderful presentation and to keep this mentorship program going. And also, few questions have popped up in the conversations. I think I'll just go through those questions. Somebody was asking about how to take Demodex. I mean, somebody's forward question is it how to take sample for Demodex? Is it from the papules? Sirisha, if you're online, can you please tell this answer?
Yes, ma'am. So Demodex, we see rosacea like papules and pustules on the face, especially in immunocompromised patients. So whenever you see a pustule, especially, just take a sample from the pustule and then stain it with it. You can do zinc or you can do KOH both.
Okay, okay. I hope this person got the answer who is on PG. And he's one person is asking which dermoscopy is the best. I think he's asking for the instrument, which is the best. Dr. Madhulika, so can you tell which dermoscope you are using so that you can guide them also?
Sure. The most of my images that I shared were DL4. Okay,
Acha.
so but there is a DL5, so I would always say go for the newer version because the newer version has UV light in it. Okay, so it is an extra layer that is added to our armamentarium, right now.
Yes,
So
yes,
I think
yes.
DL5 is the easy because for PGs they're moving around from wards to clinics, bedside, so they need something that is portable. Okay, video dermoscopes I think are somebody like more seasoned practitioners or for the colleges to buy, but for general postgraduate, I think a DL4 or a DL5, depending on their budget, would be the ideal choice.
Okay, I think this point should be taken, well taken. And one more, Dr. Sirisha, this person is asking that most of the times I am not able to demonstrate scabies mite from scrapings. Any suggestion to get it right? So, any practical tip he's asking, I think.
Yes, ma'am. So here, Norwegian scabies, it's not a problem at all. So from
Yeah.
the crusted lesions, wherever you take, it will be teeming with mites.
Yeah.
But when it comes to the regular scabies, go for classical sites, web spaces, and a burrow is the site where you have to take, if you have to look at. And here comes the role of dermoscopy again. So you put your dermoscope and you see that jet with contrail sign. So the jet with the black point at the beginning of the burrow, that is the mite. So try to scrape it from there. So then
Okay.
chance of getting the mite will be amplified.
Okay, from the depth of the burrow. Yeah, yeah, well taken. So this program of PG mentorship is going very well. If it's something like that, I have come. I just got an idea that they should conduct a test also after this one. It's something like MCQ after completing this session. If certain very important things, if you conduct a test, people will feel more confident about they have completed the chapters. I think Sudharani ma'am should think about this one.
Uh, Thank you very much, Sirisha and Madhulika, for your elaborate informative. This one is not for just to listen. This is to follow. See, this one is not for the final year students. We thought from because if why we kept this one in the beginning means in the second session means those who joined recently in the first year they start doing the procedures. That is only our wish because dermoscopy you can't learn at the end of third year. See, after doing knowing these basics, every day you put your dermoscope on the patient, whatever you get in the OP, so that it's a learning. All the postgraduates are learning like that. We need not go to any CMEs or something. Whatever basics you have, read your textbook, IADVL textbook, beautifully given all the details. And now Madhulika explained all in detail. Last year also we explained about dermoscopy. You try to learn in your routine OP days, every day, starting from day one to end. Ultimately, you will become the master. So, similarly, the bedside test, if you have adequate knowledge about this when you are sitting in the clinic, not only in the exam, this is not one important thing is for exam purpose. Second thing also in clinic, whenever you get doubt, if you have a microscope, all this KOH, instead of sending to lab, you can do it yourself. There itself, you can confirm the diagnosis. That will give more what is satisfaction to you. Even the patients also get benefited. I hope it's all the students will take all these points.
Yes, yes.
Over to Nasya. So I
Yeah.
think already it's late, I think. Yeah.
Yeah, no, no, ma'am. Still, we have 15
Yes.
minutes and it will finish before
Okay.
time. And more than 170 students or 170 delegates have joined this. That is, it was a very important topic. So I could see that many students have joined today. Thank you so much,
Great.
Sudharani ma'am, to start this very encouraging and very innovative program. And also, thank the speakers, Dr. Sirisha and Dr. Madhulika.
Thank you, ma'am. Thank you, Sudharani ma'am and Nazia ma'am, for this opportunity.
And what about technical Nasya? You just
Yeah, technical team.
tell
I
us.
think it
We
became in
have to,
between.
yes.
Some
We
almost
have
10
to,
minutes
yes.
was suddenly wasted because Madhulika's presentation was not able to be seen. It was getting switched off. So I think
No,
this.
no, we have to thank them because for arranging this one, this
Okay.
platform.
Yeah,
We
yeah.
have to thank. That
Yeah,
is for
definitely, Gloderma. I thank specifically this
yes,
academic
yes.
grant is from technical.
Yes.
No, it's not like complaining. For next time, I'm telling that we should be careful that the presentation is always already shared with the technical team so that this glitch doesn't happen. We got stopped in between. And especially thank Gloderma people to sponsor this session. And it was a very good initiative from Gloderma.
One picture, if possible.
What's ma'am?
Picture.
Picture.
One photo,
Yeah, yeah,
if
I'm taking. Yeah.
possible. Means, yeah.
Thank you. Thank you, everybody.
Thank you.
ma'am.
I've
Thank
taken
you.
the picture. I'll share.
Thank you, ma'am. Thank you.
Thank you.
We'll wind up. Any more questions are there? Shall we wind up this one?
No,
Close
ma'am,
the
no.
session.
No more questions, ma'am. No more questions. Questions are not there.
Thank you, everyone.
Thank you, ma'am. Thank you.
Yes.